For everyone else who is already here, thank you so much for joining us this afternoon, as it is where I am coming to you from, here in the ACT. Before we begin, I'd like to acknowledge the Ngunnawal people, who are the traditional custodians of the lands that I'm coming to you from today, here in the ACT, and pay my respects to their elders, past, present and emerging. I'd also like to acknowledge their continuing contribution to the life of the city and the region in which I live. And given that we have a lot of people coming in from all around Australia, I'd also like to acknowledge the traditional custodians of the lands that you all are coming from here today. And thank you to those of you who are coming from the West Coast, because I know it's a little bit earlier for you over there than it is for us here now. So thank you everyone for coming along today for our webinar, which is on the increasing complexity of alcohol and other drug work and how AOD work is getting harder and what that means for pay, conditions and service funding going forward. So there's a couple of things that have prompted us to do this event today, and we're going to try and cover a lot of ground in an hour and a half, so please bear with us while we try and do that. Firstly, what prompted this is the Fair Work Commission's recent review of the SCHADS Award that everyone will be aware of, and we thought it was a timely opportunity to get people together to talk about the implications of that, not just for the award wage rates for workers, but also in terms of service funding and indexation on government contracts and what that means for services going forward. We also thought that as part of that conversation and the work that AADC has been doing with the Australian Services Union through that process, the ASU are our partner organisation on this event that we're having today, we've also learned a lot about the increasing complexity of alcohol and other drug work as it's being experienced by people working in the sector. And we've also had conversations about what that means for service planning over time, as well as the implications of that for things like funding for services and what that looks like going forward. So, as I said, we're going to try and cover a fair bit of ground for you here today. We have got a series of speakers who are going to talk to you about those topics first to sort of set the scene for a conversation. Then we're going to go to an audience Q&A. Now, when I say Q&A, we don't just want your questions, we want your thoughts as well. So I will be asking you to punch into the Q&A section there, your questions as we go along, and also any comments that you have. It doesn't have to just be questions. You can do that anonymously, or you can identify. There are options for all of those. You'll note there's also a little thumbs up there, and that's where you can upvote other people's questions. So if someone beats you to the punch and asks a question that you want to ask before you get to it, you can just upvote it, and that'll push it up the list so it sits higher in the order of questions than before. So that's how we'll do that. The chat is actually disabled. So if everyone can bear in mind that even if you want to punch in a comment, please do it in the Q&A, because the chat is disabled for the audience so that we're all just punching our stuff into the one area there. So that's logistics, but given that we've got a lot of ground to cover, and we may spill just a little bit over the 2:30, but I'll try my best to keep us to time. Without further ado, I would like to introduce to you our first speaker, who is Kelly Thomas. So Kelly is the National Industrial Director for the Australian Services Union, and she's going to talk about the Fair Work Commission's Gender-Based Undervaluation Priority Awards Review, the implications that that has for the SCHADS Award, and next steps from the union's perspective. So thanks heaps, Kelly. We really appreciate you guys partnering with us on today's event as well.
Oh, thank you so much for having us, Mel, and everyone at the AADC. And I'd like to extend my apologies for my colleague, Philippa, who is unable to speak with me this afternoon because she is unfortunately very ill. Also, before I go, I would like to acknowledge the traditional owners of the land that I am on, the Wurundjeri people of the mighty Kulin Nation. The gender-based undervaluation proceedings, to get straight into it, really how we got here started back in about July 2024. So July 2024, the Fair Work Commission, who decides the pay rates and conditions in the SCHADS Award, initiated their own review of the SCHADS Award and 4 other awards as well, to review the pay rates, basically, to see whether or not there was any undervaluation for the work that the workers were doing on the basis of their gender. So before the Fair Work Commission commenced its review, the federal government had actually changed the legislation, the relevant legislation, the Fair Work Act, to say that any job that has suffered from undervaluation because of it being a female-dominated industry, or because there has been some other gender-based reason for underpaying women, should be reviewed. And so the Commission undertook that task from July 2024, which coincided, incidentally, with the ASU's decision to campaign for a better SCHADS award anyway. So we lodged an application 2 years ago now to try and change the SCHADS award in multiple ways, one being in relation to the pay, but also to really have a go at clarifying and making significant improvements on the classification structure. I'm sure that everybody here is familiar with Schedule B and its unwieldiness, basically. So we had embarked upon this task to redraft it in short terms. The Commission told us, can you just wait your turn about your work value case, and we'll review the classification structure at some other point. And so we patiently waited our turn and participated in the gender-based undervaluation proceedings, which largely focused on disability support workers. So I won't go into too much detail about that, but most of the evidence, a large portion of the evidence that was heard by the Commission initially was in relation to disability support work. And so that's the focus that we thought the Commission's outcome would be on. Fast forward to April 2025, when the Commission also hands down its undervaluation decision and pleasingly says, well, there is a basis for gender undervaluation, that there is a lot of, that this sector is dominated by women workers, and that they have been underpaid. The Commission also acknowledged that Schedule B was very unwieldy and was quite a problem for everyone in the sector, and just decided to invent its own classification structure and kind of imposed or suggested to impose that on us and the sector. And they used a classification structure which is very very much drawn from the Aged Care Award and the structure which is in place there, which is very much drawn from qualifications, and which is an industry where qualifications are required. And the Commission thought that it was doing the right thing by aligning these sort of care sectors to say, well, everyone who's doing aged care, disability care, and community care should be paid the same. Now, unfortunately, what the Commission didn't seem to appreciate was that actually their classification structure would have a terrible impact on the community, the social and community sector. And their proposed classification structure, if implemented, could have led to people literally losing hundreds of dollars a week in pay. And so the ASU started to fight against this, which is quite a strange situation to be in, to fight against the Fair Work Commission. Usually we're asking them to make a decision, generally in our favour. But here we were saying, please disregard everything that you have put forward and start again. Now, we had to do this in a very, very short period of time. So in the second half of 2025, we had to put on an enormous amount of evidence from the sector, from ASU members and from people from the sector, to show the Commission that actually placing a classification structure centrally and solely based on qualifications will actually lead to an underpayment and a further undervaluation of the work that people do. So for the mental health and alcohol and drug subsector, we spoke with initially around 20 people from around the country. What we found there was people were generally classified between SCHADS level 4 and level 6. We also found that there were different qualifications that people had and used. So some folks had diplomas, some folks had degrees, some folks didn't have any qualification. And what we discovered in this sort of investigative phase was that lived experience was obviously a core part of the skills and equivalent to a qualification that comes up in this in the sector. So the ASU got to work and started to draft our own classification structure, which we thought we would have several months to do, and the government had funded us to work with the sector to come up with a whole new classification structure. But unfortunately, we condensed that into a few weeks. Still, I think that ASU is very proud of the work that we put forward in such a short amount of time, and calling on the sector to really partner with us about that was a really, really positive thing. The whole sector had said we can't have this Fair Work Commission provisional view on a new classification structure, and there was like 80, so I think we had almost 90 witness statements from members and reps around the sector. There was also about 80 employers and peak groups who put in submissions saying, Commission, please don't do this. And I think that was a really, really powerful thing for the Commission to see. So where that led us to is a conferencing process that I think James is going to speak to you about, but I want to say a big shout out to James, because these conference process that we had with the Commission that were confidential, James came along to them and his assistance was absolutely invaluable, such a steady hand in such a chaotic time. So thank you, James. Where these conferences led was another version of the classification structure. And then ultimately fast forwarding to a couple of weeks ago when we actually finally got the decision from the Fair Work Commission with the gender-based undervaluation and a new classification structure. And I must say that the new classification structure is very much based on the work that the ASU did, that the people in the room did at the conferences, and I think that we are in a much better position than what we were 12 months ago, facing literal hundreds of dollars of pay reductions. I think we have successfully saved everyone's pay, protected everyone's pay, and even though we don't say it out loud too much, but there will actually be some people who go significantly up in their pay as a result of these proceedings. We don't say it out loud too much because we also, the ASU also lodged its work value claim to ask for a 35% pay increase, and up to 35% pay increase for to recognise that actually over the last 15 years, the work of the sector and the workers has completely changed, and the skills and the expertise that the workers in the sector now exercise have not actually been properly valued and are not paid appropriately. So we have we had the benefit of the gender-based undervaluation decision to be able to formulate our claim, and also to be able to see if there was anything that came out of the classification structure that we might need to fix. And one of the things that this subsector and the ASU is particularly proud of is actually that the new classification structure does provide for lived experience to be recognised and paid. That is the very first time that lived experience has ever been in a modern award, in a federal modern award, and that is a huge achievement that we should all really, really be proud of. But we also claim in our work value claim that lived experience, because it is the first time, has been recognised in an award, has never actually been properly valued. We don't know the dollar value of that work, and so we want the Commission to think about it and think about it thoroughly. So that's something that we have in the forefront of our mind as this case proceeds, as well as obviously other bits and pieces. We also, I just wanted to flag what we look at in a work value case. So the legislation requires us to prove a case based on changes in the conditions of the work, changes in the skills and qualifications, and changes in the nature of the work performed. So we've chosen a 15-year period because the last time that the wages were looked at properly in the SCHADS Award was when the Equal Remuneration Order came into play in 2012. So we're looking at that period of time. To that end, we've been conducting reference groups, which some of you have appeared on meetings like this with us, so that we can really drill down and understand the types of changes in the nature of the work that you can tell us most authoritatively. So the people on the ground are the people who can say, you know, I perform my work in different locations now. I have different practices that I need to put in place. You know, one of the things that came up in one of the reference groups was about harm minimisation. And so there's the idea that harm minimisation has actually always been part of this sector, but that it's only been recently kind of named and recognised, means that we, for our case, will frame that as a way, well, that is something. How has that actually changed in terms of the skills that you need to exercise in your work? Is it about advocating in a different way? Is it about putting in place different languages? Is it putting in place different funding models? Is it trying out different projects? Those are all things that we need to show to the Commission about how the work has changed. I just also wanted to finish up before I hand over back to Mel. The other thing that we're really excited about doing for our work value case is engaging with experts. We have quite a few academics who are also going to speak to things like the demographics of the sector, the composition of the workforce, funding models, changes like royal commissions or government inquiries that have really impacted the way that the work is performed. We'll also hopefully drag the Commission directly out to workplaces where we can, so that the Commission members can see exactly with their own eyes the kind of work that you guys are performing and why it should be valued. Thank you so much for having me this afternoon. I'm happy to answer any questions. I hope that's given a bit of a background on where we are.
Awesome, Kelly. Thank you. So we're not going to take questions to Kelly now. We're going to hold all of those to the Q&A session at the end. Otherwise, we're totally not going to get this done in an hour and a half. But if you want to, the Q&A section is live now. So if you're worried you're going to forget your questions to Kelly, you can actually start punching them in there now. But just be aware we're not going to take questions till we get to the end of the speakers. But I think that was a really good recap, and now people can see why we've paid attention to this. So traditionally, AADC has not been in the industrial relations space, and we didn't have a lot of experience in terms of the work of the Fair Work Commission. So we've really, really valued the advice and support of the ASU in being able to engage with this. Now, James is going to talk a little bit more about the process and what AADC's engagement in it has actually done for our membership. But I think that Kelly's highlighted some of the key points there. Like when we first looked at what was being proposed, some workers in the sector were looking at losing like $500 a week out of their wages. So it was not an insignificant process, and we kind of had to put our minds to engaging with it for obvious reasons. Now, the person who has done the heavy lifting there, and I just want to note the comments in the chat and the upvotes of the comment that James is a champion. Indeed, James is a champion because he has got his head around this and engaged in this process on behalf of all of us for the greater good, and become a little bit of an expert in industrial stuff in the AOD space at the same time. So good on you, James. And can you school us in terms of what you did and what you're able to achieve?
Thank you, Mel. Well, I'll do my best to school everyone. This certainly wasn't a job that I took on myself. I had a lot of help with this work. But yes, I'll take us through that in a bit more detail, and I guess give the community side of the story that Kelly's given us from the ASU side. So yeah, as Mel said, my name's James Dunne, and I'm the Policy and Projects Coordinator for AADC. And I'm coming to you from the unceded lands of the Pangarang people in northeast Victoria. Big thanks to Kelly for giving that really great overview of the Fair Work Commission's process. So yeah, as I said, I'm going to speak more to the role that AADC had as the national peak body representing the AOD sector, and take a bit of a deeper dive into some of those outcomes and what they mean for us and for all our work. So as Kelly mentioned, the Fair Work Commission's review of the awards was a really long-running process, and AADC came into the process at a point where the Fair Work Commission had put together a draft restructure of the SCHADS Award and put that out for public comment. And at this point, I do want to give a shout out to my colleague Scott Drummond at VADA for raising this and bringing it to my attention. I don't think either of us are experts in industrial agreements, so after he kind of said, oh, this thing's happening, you know, we might want to have a look at this, he and I began muddling our way through the process to understand what the implications were, what's going on, and I guess how we could respond as an AOD sector. And you know, as Kelly mentioned, to put it simply, the impact of the first version of the restructured SCHADS Award would have been significant and profoundly negative for the AOD sector. So if anybody's familiar with the SCHADS Award, you'll know that it's a really wide-ranging agreement which covers so many different social and care industries. And while there's a common focus on providing some type of non-medical care to a person, typically in a community setting, what that looks like across the different sectors is actually quite different. Yet what the thrust of the Fair Work Commission and what they were trying to do with the redraft was align all the classifications of all these quite diverse sectors into the single aged care caring skills benchmark, which, as the name suggests, is typically used within the aged care sector. But we know that our work in the AOD sector varies quite significantly to the work that you'd be doing in the aged care sector. So the people we work with are different, the risk profiles are different, even just the way we work with people is really different. And this is not to undervalue what aged care workers do and the people they work with. They play such an important role. It's more to recognise that attempting to blend all these different workforces, these diverse workforces, into a single classification structure, and one that was designed for a very specific industry, removed a lot of the nuances and the differences between the workforces, and then had a number of significant flow-on effects. So as we've mentioned a couple of times, for us in the AOD sector, these consequences were, you know, potentially coming in the form of some workers losing up to $500 a week from their pay, and creating this two-tiered workforce where people who are currently in the AOD sector would remain on those higher rates of pay that are currently in place, but anybody coming into the sector or anybody who might move roles between services, they would then go into that lower rate of pay. And of course, so this was a very significant concern for us at AADC and our members, given that we know our sector is, you know, we're low paid as it is, our roles are difficult, and there are a whole range of challenges actually getting new people into services and to do AOD work. And so I really want to thank our colleagues at the ASU for their support with this. As part of the ASU's work, they commissioned an expert academic at UNSW to undertake some of the modelling of the impacts that this first draft of the restructured SCHADS award would have. And again, I'm not an expert in industrial awards or rates of pay or anything like that, so this modelling was really invaluable to us at AADC to understand the impacts, which then enabled us to have those conversations with our members and coordinate a sector response with our state and territory peak colleagues and other AADC members. So for ASU members out there, this is a really great example of where our union dues go. And around mid last year, we found ourselves at a point where we had a draft of this restructured SCHADS award that would result in these pay drops for our workforce. And we also had the Fair Work Commission, which was quite intent on bringing these changes into effect on 1 July this year, so it would have been in a week's time. But these impacts didn't just affect us in the AOD world. There were similar impacts being felt across all the other different SACS industries. So mental health, housing, community legal centres, women's health, neighbourhood houses, just to name a few. And it was really heartening to see, up to I think about 80 different peak bodies and services across Australia make those submissions to the Fair Work Commission, demonstrating this profoundly negative effect that would result from that first draft of the restructured award. So after this round of consultation and the volume of negative feedback that the Fair Work Commission received, to their credit, they listened and they sought to develop a process to produce a better outcome for all stakeholders. And as Kelly mentioned, this was resulted in a series of what they called conferencing days. And essentially this was a process where all the interested parties would come together and sit around a table and go line by line through the SCHADS award and try to find consensus on particular outstanding issues. So we were invited by the ASU to attend and represent the AOD sector in this process. And again, because the SCHADS award is so broad, it was really important to have the voices from lots of different SCHADS sectors involved with this process, because the issues and the impacts were sometimes quite different across each sector. So, for example, we know that with AOD work, caseworkers typically start at maybe like a level 4 classification, but within the mental health sector, we found that there were sometimes they were starting at a level 3. So when the conferencing came to a point where we were discussing, where caseworkers might want to sit within the new SCHADS structure, it was important to recognise that although the AOD sector and mental health services use the same word of casework or caseworker, what this entails looks quite different, and the award needed to account for that diversity. Otherwise, there was a risk that AOD caseworkers might end up being classified at a lower level. So this conferencing process was extended a couple of times, and there were a total of 5 days of discussions, 5 8 to 10 hour days of discussions. And on a personal reflection, it was a really fascinating process to be part of, because we could really see where our work in the AOD world aligns quite closely with other social and community sector work and the challenges that they're all experiencing. But we could also see where it was diverging quite significantly as well. So it was really fascinating to see that. So the outcome of these 5 8 to 10 hour days was going through everything in detail. Was not quite consensus, but we reached a narrower list of outstanding issues, and this resulted in one final round of consultations at the start of this year. And our role as the national peak body was to coordinate the AOD sector on a position and try and get as many AOD sector voices endorsing the changes, to send a signal to the Fair Work Commission that employers and AOD workers were supportive of this restructure. So that came in the form of us preparing like a template submission that members and services could adapt or maybe put a covering letter over the top and send that in as their own submission endorsing AADC's position. And in the end, we had 13 different AOD services and peak bodies submit to the process, and importantly, all of our state and territory AOD peak bodies made submissions. So that meant that the hundreds of AOD services that we represent across Australia had their voice in that consultation process. So in the final part of my presentation, I'm just going to focus on one of the most important outcomes of the process. And as we heard from Kelly, the overall outcome was quite positive for the AOD sector and SACS sectors more broadly. And we were successful in avoiding the worst parts of that early initial draft of the SCHADS Award. And as Kelly mentioned, one outcome that was particularly important and it's worth mentioning again, and that is that we finally have the value of lived and living experience workers enshrined in an industrial agreement. And it bears worth repeating that this is a real win, and it's the first for any industrial award in Australia. We know that lived and living experience and the peer workforce has been growing in prominence in AOD services over the past decade, and the value of these lived experiences and the workers who do these roles is being recognised within the system and within all our services. But until now, there's been some critical systemic barriers that have limited the progression of peer workers who don't simultaneously hold a formal qualification, and these are hard barriers in the SCHADS Award that limit somebody with lived and living experience from progressing in their careers and have the effect of keeping wages low for peer workers. So through this new SCHADS Award, however, what it does is create an equivalence between the expertise gained through lived and living experience and that gained through study and formal qualification. So at all levels of the award, it allows for lived and living experience to be the basis of a person's suitability for the role if the employer deems that experience to be of the same value as a formal qualification. So that means that peer workers can progress further in their careers and are not met with these really hard barriers that require some formal study to overcome those barriers. And I think that's something that we can all be really, really excited about. So to wrap up, although this part of the process hasn't finished, the job isn't done. We've heard from Kelly and about the ASU's wage value case, but in reference to the SCHADS Award, we now need to do some of the hard work of preparing for the change which will come into effect in October next year, so 2027, and ensuring that any new funding agreements incorporate some of the modest pay increases that are expected, and also anticipate the implications of the award that we might not have anticipated to date. So this is something my peak colleagues and I will keep an eye on. And to finish with a reflection, I think this process really demonstrates that peak bodies work in an increasingly complex environment and need to identify and act on strategic issues as they arrive. So this work wasn't on our work plan for this year, but we could see that it was going to have a significant impact if there was a poor outcome for the sector. So that necessitated the dedicating of resources to be part of the process and help drive a good outcome. And to tie it back to today's theme, it really highlights that the increasing complexity of our work happens not just with the people that we work with and who comes through our doors, but through the funding policy and industrial environment that we all work within. So thank you.
Thanks, James. And I think you made some incredibly important points there. I mean, not the least of which is that people didn't have to cop a $500 pay cut, and that lived experience is now recognised and actually enshrined within an award for the first time ever. Those things are pretty exciting. But also in terms of us having to be responsive to some of these other processes that haven't necessarily been on our radar. And for us as a peak, and I know for the other state and territory peaks, the other issue that we need to consider coming out of this is the implications for service funding, for funding for services coming out of government, for indexation of current contracts, the implications of the changes to the award, i.e. the ones that have already happened and ones that are yet to come for that. And we know from when the national awards, the modern award system came in over a decade ago, up until this very financial year coming, we had a thing called the Drug and Alcohol Treatment Services Maintenance Measure, which was an additional budget allocation that had to be reapproved every couple of years to ensure that services would have the money to actually pay what the award wage rates are now. Now, it's taken us over a decade to get that rolled into core funding, and we're about to rinse and repeat and have that happen again. So, you know, for us as peaks, it's not just about the industrial relations process and its implications for wages and conditions. It's also about what that means for service funding. And I'm really happy that among the registered attendees at this event, we have lots of policymakers and people from departments, We've had an apology today from the Assistant Minister for Health, Rebecca White, sorry. Rebecca can't come today because she's actually in Parliament doing good deeds. We've also had apologies from some of the members of the ACT Legislative Assembly as well, who have got committee hearings on today. So it's really great that those people are also listening to this and getting an understanding of what this means, not just for us as services and workers in our sector, but what it means for policymakers and funders as well. So as James said, there's still a lot of work to do. But just riffing off some of those points that Kelly and James have made around the increasing complexity of the work over time, I'd now like to introduce Dr. Robert Stirling, who is the CEO of NADA in New South Wales and also my Deputy Board Chair. Rob's going to talk about the increasing complexity experienced by people presenting to AOD services over the last decade and implications for the AOD workforce specifically. So thanks, Rob. Take it away.
Thanks so much, Mel. Hopefully you can see the screen that I'm sharing there. Yes, great. Thank you. Thank you. I'm coming to you from the beautiful Gadigal land, looking out over Birrabirragal, which is quite rainy and drizzly at the moment. But I also wanted to give a shout out to our Aboriginal and Torres Strait Islander workers that are joining us today. And I really just wanted to start with a thank you. I wanted to thank all of the people that are working on the front line, because really that's who today's webinar is all about. And I just want to thank everyone for showing up every day, for showing up for the work that can be really challenging and it can be really complex. And we don't get paid in the way that we should. I know in talking to my peak colleagues, we're always in awe of the commitment of alcohol and other drug workers, and we have that privilege to represent those workers each day. So I just want to say thank you. You are awesome. So what is so complex about the work that we do? It's probably not going to be surprising, some of the things that I'm going to say, but I think it's really important to say it. So over the last decade, the story in the alcohol and other drugs treatment sector and harm reduction has not simply been one of growing demand. What we're seeing is a shift towards much greater complexity in the needs of people presenting to services. And that's on top of systems that have always been complex, not just for those that need to navigate the complex service systems, but for those who work in it and work alongside those people to help them to navigate it. People are not presenting to the AOD sector with just alcohol and other drug concerns. In fact, they're rarely presenting with just a single drug of concern. So over the last decade, AOD services have not simply seen more demand, they have seen more complex needs, and they've been asked to do more with no additional resources. They are the Jack and Jill of all trades. They are being asked to be mental health workers, family domestic violence workers, child protection workers, criminal justice, disability, homelessness, suicide prevention. They are responding to the social determinants of health of the people that come into our services, and they are doing an amazing job. So just in response to my last, you are all awesome, and thank you. So if we look at the system as a whole, it has grown. Nationally, the number of publicly funded AOD services have increased significantly over the past decade, and we've seen more people receiving treatment, which is great. But that growth hasn't resolved the pressure. Because what the data also tells us is that treatment figures reflect service capacity, not demand for services. In other words, services have expanded, but demand and complexity have continued to outpace that growth. What we're dealing with here is not a short-term issue. It's been an issue that has been growing for years, one that has been subject to numerous inquiries and even a drug summit here in New South Wales. It's a structural challenge, and it's largely been ignored. Now, I'm not saying that nothing has been done, but we are coming to the end of a national drug strategy. We've said goodbye to a workforce strategy and a national Aboriginal and Torres Strait Islander AOD strategy, but we are hopeful. And I guess that's another strength of our AOD sector, is our almost internal hope for change. So we are hopeful that a new national drug strategy will prioritise drug policy and those that work in it. And in New South Wales, I do want to give credit where credit's due to the New South Wales government for working with our sector on the New South Wales workforce strategy. But of course, the strategy is only as good as implementation. So we'll wait and see. But we do need to stress that workforce development is not a one-off initiative that is funded and then is forgotten about. It needs to be sustained. So the story here, as I said, is not just rising numbers, it's people. It's rising complexity. People are presenting with multiple intersecting needs, and we're asking a workforce that is already under pressure to hold increasingly sophisticated clinical, psychosocial, cultural, and compliance responsibilities. Before I continue, I just want to make something clear. The people coming to our services are not the problem here. The systems of care, the policies, and the way they are funded are the problem, because they've not evolved at the pace that we need to respond to them. So a critical part of that complexity is the rise in co-occurring needs. If you were to speak to any worker in the sector, they'll say at least 85% of all people experience overlapping harms, if not 100%. But we do need to acknowledge that people come with a specific purpose, and it may be to respond to a singular issue, and we need to respect that. But we do know that there are strong links between AOD use, mental health, domestic and family violence, homelessness, employment, criminal justice, and child protection involvement. For example, in a New South Wales linked data research study, domestic violence, parental AOD use, and parental mental health issues were strongly found to be interrelated, and children exposed to all three were twice as likely to be removed from parental care. And we know that this impacts Aboriginal families at much higher rates. So complexity is no longer the exception, it's the norm. And as a result, the nature of AOD work itself has changed. More and more, the work is about coordination. It's about whole of person care. Support and case management now makes a significant share of treatment activity. This includes care planning, system navigation, referral, and ongoing coordination across services. So the role of the worker has expanded. It's no longer about delivering a discrete intervention. It's about holding risk, building relationships, and coordinating complex care over time. AOD workers are doing more relational and coordination intensive work than ever before. And of course, it's clinically important work, but it's also labour intensive, it's emotionally demanding, and it's often under-recognised in our funding models. We can't expect AOD workers to be men's behaviour change experts, disability support workers, suicide prevention experts. But what if there's no referral pathway? What if there are wait lists for those other services? Our workers are holding this. They're holding these people because they care, and because, yes, we do have a duty of care. But how much can an AOD worker on a SCHADS award be expected to hold? And I think Rochelle's comment put in the Q&A about some of those services actively do discriminate our clients. They don't want our clients in their services. And so that means the AOD sector is holding a large number of people. But there's more. At the same time, the drug landscape itself has become more complex. We're seeing a rapid increase in new and emerging substances, particularly synthetic drugs, including highly potent opioids like nitazenes. And these substances can appear in mixed or counterfeit drug markets and are significantly increasing overdose risk. We saw the recent numbers for the Paddington Institute report recently. Drug-induced deaths reached over 2,500 people in 2024, the highest number on record. This means workforce needs to constantly adapt. Workforce capability is not static. It requires continuous investment and upskilling, and this matters for workforce planning. Staff need training in overdose prevention, emerging substances, rapidly changing markets, harm reduction, pharmacotherapy, toxicology awareness, and time to communicate this information to the people who access our services and who most need it, as well as other services. There are other service partners who need to be educated about this as well. So all of this points to a need for a different workforce model and different funding models, and an acknowledgement that salaries should reflect the work that is being done. A single discipline approach is no longer enough. It never has been. To meet the current needs, AOD services require multidisciplinary teams, bringing together clinical capability, mental health expertise, care coordination, peer and living experience support, and cultural knowledge. And so I think it's important we need to focus on the growth of Aboriginal and Torres Strait Islander workers, and of course, what we've just been hearing about living and lived experience workers. In some research that I did, we asked people with lived experience, including separate focus groups with Aboriginal men and women, what supported positive outcomes of treatment. The first thing was about the wait time. They can't get into treatment. The second thing was what supported them was having people that have been through their own experience. Having lived experience workers was the second most important thing that people going into treatment are wanting. So it's really great to see that this review is going to recognise the important role of living and lived experience. These roles are not add-ons. They're central, delivering culturally safe, effective and engaging care. Nationally, Aboriginal people make up 19% of all episodes, but for the services that I represent, it's over 26% of all episodes. We need a workforce profile that reflects the people that are accessing our services. And that includes multicultural and gender and sexuality diversity in the workplace as well. Another point that often gets missed is a hidden workload. As complexity increases, so too does the work that sits behind direct care. AOD services are expected to not only deliver treatment, harm reduction and support services, but also looking at their organisational policy, risk management, care planning, clinical care standards, reporting, outcomes measurement, data quality, all within an increasing accountability-driven funding environment. And I only know a few services that have a data analyst on their staffing profile. It's definitely an area that the sector needs support. Clinical, cultural and peer supervision are also legitimate workforce costs in high complexity settings, especially where staff are routinely exposed to trauma, crisis and vicarious stress. And we know that the proportion of workers who have access to external supervision is far below what should be available to a sector working with such complexity. The workforce conversation cannot stop at wages. We need to cost the real work: supervision, training, quality improvement, cultural capability, compliance, data, evaluation. So when we talk about workforce investment, it's not just about wages, although of course this is very important to today's discussion, but it's also about recognising and funding the full cost of delivering quality care. The final area I want to cover is how policy and funding shape how services operate and the workforce implications. AOD services operate across multiple funders and programs, including state and territory government, Australian government, Department of Health, National Indigenous Australians Agency and Primary Health Network Commission services. And this creates fragmentation in planning, reporting, inconsistent approaches to indexation of contracts, contract terms, the duration of contracts, and also the perception that retendering is best practice and will provide more transparency and efficiencies. So we're not saying that contracts shouldn't be reviewed. We're not saying that priorities don't change. We're not saying that treatment approaches evolve, but we believe that there are other mechanisms that government can employ to ensure the right services are being delivered to the right people using the right intervention. But what we do know is that these inconsistencies and approaches create an unstable workplace environment and contribute to high turnover of staff in the NGO sector. And what can be really hurtful to the sector is sometimes this turnover can be often attributed back to the fault of the employer rather than an unstable funding environment with short-term contracts. And we know that employees need security. They need to be able to know that they can pay their rent or pay their mortgage. Industrial complexity compounds this problem. The AOD sector are often covered by the SCHADS Award, which we're talking about today, but there are nurses and other allied health workers and medical professionals that fall under other awards, like the Nurses Award, the Health Professionals and Support Services Award, and that increasing complexity in workforce planning and budgeting for a CEO of a service with those multiple awards. Fair work processes in recent years have also highlighted how complex and shifting award structures can create implementation and cost pressures for employer. Imagine being an employer with funding across multiple funding sources and multiple salary increases, and then one of those funders doesn't provide indexation, the other one does, the other one provides a small amount of indexation. What results is that when people leave, new positions are not filled because they can't afford it. So a reduced workload and a reduced capacity to deliver services, resulting in treatment access issues. So in other words, the workforce problem is complex. It's a consequence of fragmented contracts, inconsistent indexation, industrial complexity, and policy and funding that do not fully fund the real cost to deliver contemporary AOD care. So where does that leave us? The AOD sector is now delivering much more in a more complex environment with more complex clients, more complex risks, and higher expectations around outcomes and compliance. But policy and funding models and awards, and in some cases workforce setting themselves, have not kept pace with that reality. If complexity has increased, then investment must increase too. We need funding that supports multidisciplinary models of care, Aboriginal and living and lived experience workforces, trauma-informed care, integration with other health and social services, and growth on contracts and awards that reflect the work that is being done by the sector. And just as importantly, we need funding that covers the true cost. So the question is no longer whether complexity has increased. It has. The real question is whether our awards, policies and fundings will catch up with the reality of contemporary care, because if we don't, the system will fall short of what people and communities need. Thank you.
Rob, nailed it. I think, in the context of what Rob's saying as well, it's important that we really do emphasise the emotional burden on people working in the sector and how that has increased over time as well. We've had a situation where for at least the last 10 years that we know of, up to 500,000 Australians are missing out on alcohol and other drug treatment each year in Australia because of a lack of capacity in the system. We've also seen from the latest Pennington report that's come out, their snapshot of overdose deaths, that we've now topped 2,000, and overdose deaths in Australia are now twice the national road toll each year. And the impact that that has on the people who work in our sector and the people working in treatment and harm reduction services cannot be overstated. Makes me very emotional. I was a frontline worker 20 years ago and I burned out and I can't do that anymore. And I hope that in what we're doing now, we're actually, I guess, standing behind you and trying to push things forward in terms of funding and capacity for the sector. But acknowledging what Rob said, it's a really hard sector to work in, and you guys do the hard yards every day. And if we can assist and support you in some small way to do that work, then I guess we're doing our jobs as best we can. But, you know, there is some hope. We currently have an inquiry at the federal level on the health impacts of alcohol and other drugs in Australia. That's a federal parliamentary inquiry that's going now. And we will be providing, we've had some engagement with the committee on this event even this morning, and they will be providing a copy of the recording to the committee members. And one of the committee members, Dr. Gordon Reid, in his previous work, was a doctor working in a withdrawal unit in hospital settings. So we do have people from our sector working in places that are in a position to make a difference. So that's really heartening as well, and important too, I think. So what we're going to do now, though, is go to Dr. Kirrilly Thompson from NCETA, the National Centre for Education and Training on Addiction, because Kirrilly's got some data to back up all of these stories that we're telling and all the things that we're saying. Kirrilly's going to talk to us about the findings from NCETA's 2019 to 2020 workforce survey, focusing particularly on NGO AOD workers. Thanks, mate. Take it away.
Thanks so much, Mel. Let me get this share screen happening. Okay, you're looking at my PowerPoint? Excellent. Great presentation so far. I'd like to give you a fairly upper-level statistical kind of presentation and look at what we actually know about this workforce at a national level. So I'll be talking through some findings from NCETA's National Workforce Survey that was conducted in 2019 to 2020. And I'll be focusing in particular on the NGO workers who very generously participated in our survey. Before I do that, though, I would like to acknowledge that I'm on Kaurna land today. It's unceded land. I pay respects to Kaurna elders past and present. And in particular, I'd like to recognise the ongoing impacts of colonisation and structural inequity that continue to shape the health and social outcomes for Aboriginal and Torres Strait Islander people, including those related to AOD use. And I'd like to extend special acknowledgement to Aboriginal and Torres Strait Islander people joining us today. I'm pretty sure everyone attending knows who NCETA are, but in the off chance that you haven't come across us before, we are one of the key national AOD research centres in Australia. We have a particular focus on workforce development. We are based at Flinders University in Adelaide. We've been around for about 34 years now. We work for a Catalyst for Change, and we're funded by the Commonwealth Department of Health, Disability and Ageing. I would like to take this moment to let you know about 4 of our offerings. We, of course, have our own website where you can find out about the research work that we do, but we also run the National Alcohol and Drug Knowledge Base, where we keep some very thorough and up-to-date statistics about AOD use. We have a screening and withdrawal tools collection with guides about how to use screening and withdrawal tools and information about the different populations in which they've been validated. And we have NCETA's Work Life website, where there's a whole lot of resources for workers, organisations and managers about AOD in the workplace and use by workers, and we look at that from a health-based perspective. So let's get into the data I'd like to talk about today. As I've said, it comes from the 2019 to 2020 survey that we did. That was only the second time that a national AOD workforce survey has been conducted in Australia. The first one was in 2005. You can use this QR code to go to our website where we have extensive information about this survey. You can see the national report, you can find infographics, there's a user manual with the full survey protocol. We also have some summary data on key items in case you would like to compare data from your own workforce or jurisdiction. And we have a list of the publications that came out from that survey. So some deep dives there into topics like lived living experience, workers in regional, rural and remote areas, AOD nurses and counsellors, workers at different stages of their career, and the NGO workforce in particular. And I'm going to give you some highlights about that workforce today based on one of the publications that you'll find at that website. First, I would like to acknowledge everyone who was involved. That was a massive project which involved getting ethics from multiple jurisdictions. It was a huge feat. Some people dialing in today might be listed on this page. If you are, please give a little hand heart emoji thingy. Special thanks to you. This is ongoing research, and I think you'll be glad to see that we're, hooray, I can see a heart across the page. Couple there. So thank you so much. We continue to use this research. It's really important. And today is an example of that impact. The survey itself was based on existing jurisdictional surveys, as well as validated instruments, and with advice from the NCEDA team and an expert advisory group. It covered a whole lot of things, and you're going to get quite a spattering of these today. Demographics, employment and client characteristics, qualifications and professional development needs, working conditions, organisational characteristics, recruitment and retention, and worker health and wellbeing. The survey was open from 2019 to 2020. You'll all remember that as COVID time. So it was at that point that the data were captured. Now, we really opened that survey to anyone involved in the AOD sector. We included specialist workers, workers from any organisation in any particular role across all sectors. So a real mixed bag there. It was a pretty typical sample, but it might not be representative of all the workers across Australia or those particularly in your workplace. Over 1,500 people participated in that survey. 888 of those were in direct client service roles, and 514 of those were NGO workers. So let's hear a bit about what those workers look like and what their concerns were. This information is coming from this particular peer review article that you'll be able to find in the Drug and Alcohol Review. You can link it from this QR code or you'll find it at that survey website. So big thanks to Anne Roach and Natalie Skinner for preparing that publication. All right, the workers I'm talking to you about today, the NGO workers in direct client roles, 69% were female. 35% were aged 50 years and over. 42% had caring responsibilities. 8% were Aboriginal or Torres Strait Islander people. Over half had personal lived or living experience. And almost 3/4 of those workers worked on the East Coast, which is fairly consistent with a lot of national surveys across Australia. Let's look now at their qualifications. Over half had a general tertiary qualification. Almost half had an AOD tertiary or VET qualification. And 60% had any AOD vocational qualification. If we look at their experience in the sector, this was split, fairly consistently into thirds, where around 1/3 had been in the sector for 3 years or less, another third between 4 and 9 years, and another third had 10 years and over of experience in the sector. In terms of experience in their current organisation, 67% had 3 years or less of experience, 29% had 4 to 9 years, and 12% were the stayers. They'd been in their organisation for 10 years plus. I think that really shows some real commitment to people's organisations. It's a really good reflection on the workforce. In terms of people's employment demographics, most people were permanent, 59% were full-time, and most were working in metropolitan areas. In terms of salary, what the authors of this article did was compare people's salary with the Australian national average in 2020. And they found that around half of the NGO workers were receiving a salary below the national average, around almost a third at the national average, and only 1/5 above the national average. In terms of people's job quality, half were satisfied with their pay, most were satisfied with their current job, and most were satisfied with the AOD sector as a whole. When it comes to overtime, 38% of workers were frequently doing overtime. 14% were receiving financial compensation for that overtime, but mostly people were receiving time in lieu for their overtime. In terms of workforce sustainability, a quarter of workers perceived their job as insecure. 59% felt respected and supported. 42% frequently thought about leaving their current job, and 59% frequently thought about leaving the sector. I'll be really interested if people have comments about these or any of these statistics that we can discuss in the panel. In terms of worker wellbeing, 40% rated their health as very good or excellent, and around half felt burnt out. Now, we did ask in the survey what people thought their professional development needs were, and I've pulled out the 3 needs for which more than 50% of people agreed that this was a need. So the first one is complex needs of clients, and I think Rob spoke to that really well. This is something where has always been the case, but is increasing, especially with cost of living pressures, increasing homelessness, and new and emerging substances. Other development needs were service delivery, partnerships, and multidisciplinary teams. I think increasingly we're seeing people recognise the expertise of others, reaching out and working in teams. 57% of participants felt that there was a need to develop their management and leadership skills. And for some context there, around 15% of people in this survey who were in direct client-facing roles listed management as their main work role. So this is a workforce with management and leadership skills and demands and responsibilities. So I'll leave that there for my upper level view of statistics. I hope there was something there that really resonated with you in terms of your curiosity, something you want to know more about, or something that really reflects what you're seeing happening in the sector right now. And love to hear about that in the panel. What I would like to leave you with is an awareness of some resources that we've developed to look after our amazing workforce. The first one here is a stress and burnout prevention guide for everyone working in the sector. We also have a really popular resource for Aboriginal and Torres Strait Islander workers called Feeling Deadly, Working Deadly. That comes with a whole lot of different resources and videos prepared by an awesome team. We're really, really proud of these resources. Other things that you might like to know about is the Peer Workforce National Framework. There's a link here where you can register for updates about the forthcoming full national framework. This will be Australia's first framework for supporting people with lived-living experience of illicit drugs in the workforce. But you will also see that there has been released a practical national framework snapshot. It looks like that great production on the left. I really recommend you read that. So thank you so much for being here. Really interested to hear your reflections on the data I've presented. It's about 6 years old, so I would really like to know if these things still apply, if they're now increasing, intensifying, exacerbated by what's going on in the broader context.
That's awesome, Kirrilly. Thank you so much for that. In terms of the peer workforce framework for enthusiasts of AADC online events, we're going to have another online event about that when it is finalised and released, so stay tuned to hear about that one. I think what Kirrilly has been able to show us really kind of bears out what the other speakers have said, and particularly speaks to what Rob was talking about as well, and some of the comments that we're seeing there in the chat. And just in terms of talking about other awards that are related to the SCHADS Award, there are a couple of comments in there around some other awards, and Rob mentioned other awards as well in what he was talking about. I'd just like to read out now, before we go into the panel and Q&A session, some input that we've received from Darren Smythe, who's the Director of Next Gen Nurse Practitioners. Many of you will know Darren from his long association with Dunne, the Drug and Alcohol Nurses of Australasia, and he's now gone on to be a Director of the new organisation Next Gen Nurse Practitioners. Darren's not actually able to be with us today because he's out doing good deeds and actually seeing clients and stuff, but he did provide some text for me to read out that lovely Pete has now popped up on the screen for you there. What I'd like to do is just give you a chance to have a look at that, because I think it'll really resonate with some of the comments we've already had, but also to highlight some of the key points that Darren's raising there. So Darren starts off by saying that over the last 25 years, the specialty of AOD nursing has evolved into one of the most complex and demanding areas of healthcare practice. He points out that the patient cohort has also changed dramatically. 25 years ago, the average person presenting to an inpatient withdrawal unit was in their early 30s, and today that average age is commonly in the early 40s. With increasing age comes increasing complexity. Patients are now presenting with multiple chronic physical health conditions alongside substance dependence, creating a level of clinical complexity that extends far beyond withdrawal management. Historically, an AOD nurse working in a detox unit was primarily expected to understand withdrawal syndromes and their management. And while this knowledge remains fundamental, contemporary practice now requires advanced assessment and management skills across a broad range of specialties. Nurses must possess a sophisticated understanding of neurological disorders, cardiovascular disease, respiratory illness, liver disease, and other gastroenterological conditions, endocrine disorders such as diabetes, dermatological presentations, infectious diseases, chronic pain, frailty, and aging, and the impacts of long-term substance use on virtually every body system. Simultaneously, they must navigate complex mental health presentations, trauma histories, cognitive impairment, acquired brain injury, and escalating psychosocial needs. Darren goes on to point out that the emergence of new psychoactive substances and increasingly complex patterns of polysubstance use has further intensified clinical demands. Withdrawal presentations are now no longer limited to alcohol, opioids, benzos, and stimulants. Nurses are now managing withdrawal and behavioural complications associated with synthetic cannabinoids, novel stimulants, pharmaceutical misuse, and combinations of substances for which evidence-based treatment protocols continue to evolve. This requires ongoing education, advanced clinical judgment, and a commitment to lifelong learning. Darren goes on there, and I'll let you read some of those other bits in there, but he talks about the increasing administrative load that Rob spoke about as well. And he talks about as well some of the challenges in terms of occupational risk, and that these realities can make AOD settings less attractive as student placements and early career employment opportunities, further exacerbating workforce shortages. Now, there are some comments in the chat that go to that as well. But Darren points out that despite these challenges, AOD nursing remains one of the most rewarding and impactful areas of practice. It is a specialty that demands highly developed clinical reasoning, exceptional communication skills, trauma-informed care, advanced physical assessment capabilities, and a deep understanding of addiction, neuroscience, and recovery. Modern AOD nurses are no longer simply managing withdrawal, they're caring for some of the health system's most vulnerable and medically complex patients. And I think that's, I think really bears out, even though we're talking about a staff under a different award there, it really bears out the themes of today's event and talks about as well the different workforce profile that's increasingly being required across services as well, because we're not just talking about hospital settings, we're talking about the kind of clinical staff that are now required within services. And there's some comments there in the chat that go to how great it is that award pay rates have gone up, but again raise that issue around whether services can afford that and what that means in terms of recruitment and retention of skilled staff going forward. And I think what Darren's comments do there just reinforce that that increasing complexity requires an increasingly professionalised response and is changing the workforce profile and the level of skills and experience that people are requiring across a whole range of occupations in the AOD sector. So I'll leave you with that, but I just wanted to throw that in because it goes to some of the other comments before we go to our panel session. So what I'm now going to do is go to each of our speakers so far and just ask them for their reflections on key points from their presentations, because obviously they all knew what they were going to say, but they didn't necessarily know what the other speakers were going to say. And I'm sure that there's been some learnings for everyone in that. So what I might do is throw to the speakers first, and then we are going to delve into the Q&A section. So if you haven't been in there already and punched in a question or a comment that you would like to give, please do so now. And please take a second too to scroll down and upvote any of those other inputs in there that really reflect some sentiments that you've got, because if it's already covered by someone else, don't feel like you have to reiterate it, just put a thumbs up on it, and I'll go through those after we've gone to the speakers, starting with the ones with the most upvotes on them. Yeah? Okay, rightio. So I might do this in reverse order, just so that Kelly doesn't have to go first again. Kirrilly, would you like to start by just reflecting on what you learnt from some of the other presentations today?
I think overall what really stood out to me is the amazing support that our workforce has had from people in the background for a long period of time now. And I'm really grateful to people like James and Kelly and the union who have been advocating for our workforce. That's the first thing that stands out to me. I'm obviously thrilled that lived living experience is now recognised. I think that is a huge win. I think that will have really good flow-on benefits, not just for LLE workers, but for reducing stigma in general. So I couldn't be happier about that. Listening to you reading out those comments just now, I wrote something down, which I think summarises my thoughts right now, which is that as client complexity increases, workers need at least an equally complex mix of knowledge, skills, and attributes, but they also need the support to use them well and to use them sustainably.
Yeah, look, I think that's some completely valid reflections there, mate. I think you've kind of nailed it there. Rob, I'm going to go to you next, because certainly you're up with the complexity, but have been less across some of that industrial relations stuff. How do you, as someone who represents services and understands that funding environment and workforce planning processes, what are your takeaways from what we've talked about today?
Well, I think, look, it was really great to hear from Kelly and James to have a deeper understanding of the process. And I guess Kelly mentioned the ERO, and then Mel, you mentioned the DATSM, which is what happened from the ERO became the DATSM for the drug and alcohol sector. And just thinking ahead about what this process means for the sector going forward and how we bring our funders along with this. And we don't want to see another ERO DATSM experience for the sector, because it's, you know, it's not good for anyone. It's not good for the services, but we know it's also not good for the Community Grants Hub and others that are managing that in the background as well in terms of how those payments are processed on. So I guess my reflections are, how do we think ahead to make sure that whatever the outcome is, that we work collaboratively with the funders of the sector to make sure that it's a really smooth process for everyone. And Kelly, happy, as I'm sure AADC is, to support access to AOD services to get the commissioners out to see what the reality is and make sure that they see a diversity of AOD services in action.
Yeah, thanks, Rob. And I think, you know, those funding implications are really important for us to highlight, particularly in the context of the current AOD inquiry at the national level, but also in terms of broader funding structures, things like indexation, how indexation is calculated for services that are funded by both the Commonwealth and state and territory governments is something that needs to be considered over time, and is something that we're certainly talking to our colleagues at ACOS and in other national peaks about as well. So James, I'm coming to you now because we're going in reverse order. I'm sure not a lot of this has been a surprise to you, but what do you reckon are the key takeaways from all of this, given that you've kind of had a foot in both camps there?
Yeah, thanks, Phil. Look, there's so many things that have come up for me, but I'll just focus on two quick points. One is around this, Rob's point around the AOD workers and holding these people in the services and all the different sort of issues that we need to be across when people come through our door. And I reflect on some of the other work that AADC has been doing around workforce development around fetal alcohol spectrum disorder. And I know some of my colleagues at 𝐂𝐴SD Australia are in the audience today. When we've been doing these trainings, we've had hundreds of people turn up to these webinars, to our in-person trainings, which really demonstrates that there is a need. There is these intersecting issues that frontline AOD workers are having to address, and fetal alcohol spectrum disorder is one of those. So it's just an example of that need out there, and I guess a reflection of the environment that we're all working in at the moment. But the second one I think was from Kirrilly's presentation was that so much of our workforce is either at the average pay or below, but we've got good satisfaction, yet at the same time there's burnout. So I think that just really highlights the dedication of our workforce to this work. People want to be doing this work. We care about it. We're passionate. We want to stay working in this sector, but we need the conditions and the pay and all this other stuff to sit behind it. So I think the work that the ASU is doing around this work value case, and actually saying that these workers are creating more value than what we assumed in 2012 when these pay rates were set. We actually need the conditions to catch up to the workforce and the conditions that they're working in now.
I think that's right, and there's a whole lot of ways that we need to consider this, I think, moving forward, but that complexity and what that means, and I think Rob made the point as well that often the people presenting to AOD services are people who have been bounced from other sectors because of difficult behaviours, or indeed the level of complexity and the fact that they don't fit neatly in anyone else's box. But the fact that they're not being bounced from our sector is an incredible credit to the work that the people in our sector do, and to the services that they are inclusive of people who have that complexity. But it also reflects why we need more in terms of resourcing, and why our staff do tend to be highly skilled, because they've evolved that way. They need to be. Kelly, you have been a huge friend to us in this process, mate, as have your colleagues at the ASU, but we feel like we've kind of thrown you in the deep end of AOD sector stuff. What have you learnt from this experience?
It's really funny. I've actually only been at the ASU for 1 year, so I have been in a very, very steep learning curve, understanding so many sectors. But actually, one of the observations I was going to make that really personally resonated with me was that there are more overdose deaths than car accident deaths. And I used to work for a state government transport department, and I know the enormous amount of resources that went into getting that number to zero. And so that just really, really struck me. It also, the support, this supportive network, these beautiful people, this sector is really, really lovely. And I'm so thrilled to actually just get to do this with you, that we get to do this together. And I think that was going to be one of my other reflections. Rob, everything you just said, we need to tell the Fair Work Commission. And that's exactly the kind of information that we will present to them, to say, here is why people need to be paid more. You know, pay is certainly only one thing, but it is a big thing. And so that's something that we can do actively and proactively. So really pleased to do that. The other thing I was reflecting on was Darren's comments as well, and there are other care. Care is the word used that the Fair Work Commission uses. I'm not quite sure that it's comfortable with me yet, but other care sectors are going through the same things that you guys are in terms of that. The sheer volume, the change in the nature of people and their needs, no wrong door policy, I think is something that seems to be coming up as well. That, you know, if there is a last resort, place of last resort as well, like these are things that that other sectors have tried to grapple with, and they have run other cases running similar things. But it just means that we have to be a little bit more creative and a little bit more reflective of this sector and the members who work in it. So once again, thanks for having me. Looking forward to some questions.
I think we're going to go into the Q&A now, and I'm just going to mention to people that I am going to go a little bit over time on this. We're at 2:21 now, and I want to have at least 15 minutes worth of conversation here. So I will try and smash out what we can, but don't freak out because we are going to spill a little bit over the 2:30 mark. Rochelle, your question has been upvoted the most, and I think we have covered some of it, but I do want to revisit a couple of elements of that. Rochelle McIntosh, it would be of significant value to consider the responsiveness of the AOD sector to intersecting concerns, which means ongoing capability building for sector workers to other specialty issues, co-occurring family and domestic violence, cognitive impairment, etc. Notably, this is due to other sectors being less responsive or not at all to alcohol and other drugs. So there's two things in there that I want to throw to you first, Rob, and then maybe Kirrilly, about this ongoing sector capacity building. James has mentioned FASD in particular, but it goes to that need for capability building and the implications of that for service resourcing, but also around this idea that we've all touched on around some other sectors being less responsive to complexity, and that ending up in the AOD sector because of that, when really we would argue that perhaps someone with schizophrenia, for instance, might be better placed in the mental health sector, but because of their concurrent alcohol and other drug use, they end up with us. So both of those issues related, the need for ongoing capability building and the fact that our sector is tending to pick up the most complex clients. Rob first and then Kirrilly, what do you think the implications of that are for workforce and for services and funding too?
I mean, I think I mentioned it in the presentation. I mean, I think what it means is it sounds exhausting for the workers. I mean, the people that they're the ones that are facing the reality. I mean, I think peak bodies play a really positive role in building workforce capability. We developed a workforce capability framework to kind of develop by and for the sector, but it wasn't resourced. And I guess that's what we need. We need to ensure that the workforce development and capability building is resourced in an ongoing way. And that need will look different from different services and different states and territories. The other part about the cross-sector issues is it's such a challenge, and I know that we've been really lucky at NADA to have a position that's been funded to build some of those cross-sector partnerships, and it goes to the need for a whole of government national strategy, AOD strategy, that isn't just health and law enforcement, that really brings together the entire health and social services sector. But the answer is complex, and we can't do it alone. I think the responsibility also needs to lie with mental health and the other interrelating sectors to build capability at the same time.
That also goes, Rob, to the need for a national governance framework for the sector, particularly with ministerial level engagement, so that those ministerial leadership roles can reach out in a whole of government way to ministers in other areas to bring up some of this some of these issues around the need for more connected responses in connection with complexity. We talk about housing, we talk about disability, we talk about domestic and family violence, but without those connections at really high level government levels, it's very difficult to get that sort of joined up response. That's probably a comment rather than a question. Kirrilly, what were your additional thoughts on that topic?
Yeah, I think that no wrong door policy that is so important and effective in our sector means that generalist and specialist AOD workers are seeing clients for whom AOD may be the primary issue of concern or may not. So our workers need to be experts in AOD, but they also need expertise in FSDV, in mental health, in all the other co-occurring conditions we've spoken about. Obviously, that points to the need for education and training. We have some great vet courses. We have disparate resources and workshops and webinars. There's a lot of great work going on. But if our workers are stretched for time, are they actually being given the time and the support to engage in these educational activities? Are they being provided with funding from their workplace to be able to engage in them? So my concern is that the more push for time workers get, the more expertise they need, but the less time and support they have to get that expertise. So they're learning on the job, flying by the seat of their pants, which I'm sure a lot of people, I'm sure that resonates with them. So we really need that funding to create the space and time. We need funding that has education as part of its modelling for workers. And we need to be evaluating the quality of the education and interventions and resources that we have so that workers can make really good choices about where to invest their time.
Thank you. And I just want to point out that the comments you guys have just made connect with a number of the questions in there. So there was another point in here that there's a growing perception that complexity in AOD work is increasing. And to what extent do you think this reflects a real change in client complexity versus a shift from earlier service models that often excluded people with higher or more complex needs? And I think it's kind of a little of column A and a little of column B, because as we have worked really hard to increase the inclusiveness of services, what that means is the services have been more inclusive of people, including those with more complex needs and challenging behaviours. And so maybe people aren't getting more complex than they were before, but certainly us letting people into services and being more inclusive of services has meant that there is an increasing need for a response for that as well. And I think that goes as well to some of the comments in here, Kelly, and I'd be interested in your views on this around occupational violence and managing challenging behaviours in the workplace. I mean, that's certainly an issue across multiple sectors. And, you know, I spent a little bit of time out of the sector for a little while and was the Chief of Staff for an Education Minister. And certainly we're seeing that in school settings as well, where we're trying to be more inclusive of kids with disability and that sort of thing. It does mean that classroom teachers as well need to be able to respond to challenging behaviours in those sort of contexts. And just that way, we're seeing it in the AOD sector as well, where we're striving to be more inclusive of people with more complex needs and with disability. But that does present more challenges, as Rob and Kirrilly have just highlighted, in terms of the skills that workers need to be able to respond. But it also goes to some of the challenges, you know, in terms of occupational violence and that sort of stuff as well. Kelly, do you have any reflections on that, given that you've been in some other spaces where this is an issue?
Yeah, thanks, Mel. It's a really interesting question. A long time ago, the Fair Work Commission, actually its predecessor, said that it won't pay or it won't value danger money. So you don't get paid more because the work is dangerous. The Commission basically said that's the role for workplace health and safety and that scheme of regulation. Now, the Commission, however, did say in the aged care case that you can only minimise risk so far. And the issue that I think the AOD sector and other sectors in SACS is that you can't eradicate the risk of vicarious trauma and burnout. And while we can't say, therefore, you need to be paid that, what we can say is, because of those things, because of the risk of vicarious trauma and burnout, workers have to exercise particular skills and learn new ways to manage those things, and those things should be paid. So, you know, vicarious trauma, I think, like debriefing, like having debriefs with your colleagues at the end of the week, and having someone that you can speak to, having someone that you can, you know, joke with, or whatever it is, your preferred method of debriefing, that's a skill that people have to learn and that they should be paid for. So it's true that the award process will not really be able to completely fix that issue. There is a space for workplace health and safety regulation, but what we're trying to do in the award case is to say, well, this does exist and it is a skill in managing it, and that should be paid.
I think that's a nice segue into one of the other points that I want to make that comes out of a number of the comments and questions in here as well, which goes to resourcing for services and funding for services going forward as well, because we're talking about whether we're talking about increasing, you know, professional supervision, whether we're talking about being able to pay people commensurate with their skills and experience and qualifications in responding to greater complexity in the workplace. All of that means that services need to be funded and resourced adequately to be able to actually do those things, yeah? So I think there's really a piece in that for us in terms of funding for services and organisations and lobbying government around that, because we have this recognition from the Fair Work Commission, and recognition is building around the increasing complexity of the work and I guess the whole of government responses that are required. But what is not keeping pace with that is funding for services, you know, and if we already have 500,000 Australians missing out on treatment each and every year, and we have overdose deaths that are now double the national road toll, clearly we have an issue around the resourcing for existing services not being enough. But if we're saying that we need to pay more and services need to be able to have more highly experienced staff, we're going to need to pay more for what we've got now, let alone building on that. So I'm wondering, James, given that you've had a foot in both of these camps, I might go to you and then to Rob for some reflections on those comments.
Thanks, Bill. Yeah, as I said in my presentation, I think that part of the work is not just seeing that this Fair Work decision comes out, but it's now working with funders and really communicating the outcomes and keep on advocating for those pay increases and the different impacts that those agreements are going to have, for that to be built into funding contracts going forward. And as Rob said, we don't want to get into this situation where we have another DATSM or ERO process where we have these little top-ups of funding going along. We want that to be part of core funding, and then to be able to grow that core funding to be able to actually fix the waiting list that we know that are out there, and provide support to the people who can't get access at the moment. So I think us and our peak colleagues in all the states and territories are having those conversations with funders constantly, bringing up these issues around waiting lists, highlighting the needs of the sector to try and start building that funding profile for us.
Rob?
Yeah, I mean, look, I think James covered that really well. I think the Fair Work Commission will have a lot of weight, which will help us. It doesn't help us in the true cost to deliver services, some of those things that I spoke about in terms of the compliance and supervision and other things. And I think that is something that we continually need to tell government about, what the true cost is. We worked with New South Wales Health on a business and funding model study that went to that cost to say, what does it cost to deliver a residential rehabilitation service or outpatient counselling service, for example. But unfortunately, sometimes these documents are developed and they're not implemented. And so I think we have the evidence. And so I think that collective advocacy is something that we really need to lean into and work together.
going to group another couple together here, and then I'm going to go to you guys for final comments because I know that we're now over time. So the last question that's just dropped into the chat, I think, is a timely one. The Department of Health have publicly stated the funding level they will provide for the DAP, which is the Drug and Alcohol Program, for the next 3 years won't change. Does the panel expect any movement in this figure based on today's discussion? Well, not in terms of the current DAP reform process, but certainly, as I've mentioned, we have a current parliamentary inquiry in play, which is likely to come out with recommendations by the end of the year. And certainly I'd be very disappointed if there wasn't some recognition of the need for more funding and capacity from the sector coming out of that inquiry, because I'm not sure that they could speak to many people in the sector and not get that impression. But it also goes to what we've talked about in the terms of the need for national governance. We now need to develop a new national drug strategy, and it's really important that there's a national governance framework in place that brings together the ministers from the Commonwealth and the state and territory governments, as well as people from the sector, to consider the development of that strategy, but also how it's implemented going forward, and also who have capacity to consider how it's resourced. Because we all know that strategy is great, but if there's not money to implement them, then they don't go very far. What I might do is just tie another couple of questions together here. Some services, here's a comment, some services will not accept a referral for other issues until the client has engaged with an AOD service. This can happen because wait lists are too long, or it can be because general workers don't have competency working with AOD. Some believe the client won't have capacity for general counselling if they haven't dealt with their AOD use. And I think that speaks to the points we've made around how the AOD workforce is often called on to respond to people who have what we might consider primary problems that cut across other areas as well. And I'm mindful of another comment that's further up that I thought was really interesting from Donovan. What is complex? As all clients have some form of complexity. No one comes with singular issues. No, Donovan, they don't, and especially not in our sector. But I think the fact that you're saying that also reflects to me how accepting and adept people working in our sector are of responding to people with complexity. You're going, why are we talking about this? This is just core business. Yes, it is for us, but for others, sometimes not so much. So with that in mind, I'm going to go back to each of the panelists to comment on the AOD sector's role, the increasing complexity, and anything else that you think you've got out of the discussion today that you'd like to share before we finish it off for the day. Kirrilly, I'm going to start with you this time, mate. Sorry to put you on the spot.
I might instead take the opportunity to ask a question, or to leave an open question to everyone today. I'm really interested in documenting changes that we've seen across the sector since 2012 that have increased demands in terms of those things that Kelly spoke about earlier around work conditions, skills, and the nature of your work. And I'm really interested in things we can point to, evidence in terms of you now are required to have a qualification you didn't before, or a particular new piece of knowledge, new legislation, new requirements, new demands, new patterns of substance use or emerging substances. The researcher in me really wants to pin down what's the evidence behind this, because as somebody commented, clients have always been complex. But what could we really point to say that that complexity is increasing? So that's where my brain is going. And if people have thoughts, I would be happy to receive them at my email, or you can send them through to Mel, and I'm sure she'll pass them on for me.
Okay, what we're going to do is drop a couple of contacts in the chat here, because you've actually just done something else that I was going to do. You've already stepped ahead of me here. No, it's actually really good. Because Rochelle McIntosh also put in the chat there, would sector case studies be useful, representing a range of service types and settings and service users, their journey and how the AOD sector responds, drawing on their workforce skills, qualifications and the organisation systems that support effective service delivery. And James has answered, that'd be really useful, Rochelle. Anyone with a case study on AOD work can get in touch with me directly, or at contact@aadc.org.au. James, do you mind just punching into the Q&A both Kirrilly's and your email addresses for that purpose? Because we would love to receive your case studies, and I know that Kelly would love to see that stuff too. So You know, if anyone would like to tell a story that illustrates the level of complexity that's presenting from any of those perspectives, we'd really welcome receiving that, and we'll pass those on as well. So thank you. You just did another job for me. So we've tick that one off the list. I'm going to go now to Kelly. Thank you so much, mate, to the ASU and to you for partnering on us with this event and also in the work that we've been doing. What would you like to share as a last thought for the day?
Yeah, look, I think I also wanted to flag, I guess, that ASU definitely has an industrial interest in terms of the award as well. But I want everyone to know as well, we are actively lobbying and advocating to fund this pay increase. We don't think the sector should have to do it on its own. We're all in this together. And so we are using the levers that we have as well to try and get this funding for organisations who hopefully won't need to demote anyone or anything like that, because we just want people to be paid what they're valued. Definitely worker case studies are absolutely critical for this case. So if you want to provide a case study to Kirrilly or to James, but also one thing that I need as a lawyer is to actually put people's witness statements together and to give that to the Commission. So if anyone is interested in doing that as well, please do sing out, because that evidence is absolutely critical to us winning this case.
Awesome, thank you. So what I think we're going to do is put up some email addresses, but what we might also do, because I know that we had a lot more people registered who had to go back to work and weren't able to hang in for the whole thing today or weren't able to come along, we might send out an email afterwards asking for those as well to everyone who registered. A couple of people also asked about presentations and whether they'll be available afterwards. A recording of this event will go up on the AADC website within a week, and for those speakers who had presentations, we will do a whip round and see if they're happy to have those published on the website as well. So that's there too. Rob, let's go to you. What would you like to share as your last thought for the day?
I'm going to be super quick and just finish how I started, which was thanking everyone, thanking the sector for everything that you do, and just picking up on Kelly's comments. We've got your back, and that's what we're here to do. We're going to work collaboratively with ASU, with the AADC and all the state and territory peaks, as well as with Kirrilly and the team at NCEDA as well, to make sure that we've got that evidence to back up our claim for what we need to increase funding to the sector.
Thanks, Rob. And James, since you've done so much of the heavy lifting on this for us, and you are across the policy framework and the industrial relations stuff, I'm going to give you the last word of the day. What would you like to share in terms of last thoughts about all of this?
Look, I think being involved with this process and working at AADC over the past 4 years and being involved in and around the AOD sector for longer than that, you know, I know we've got a dedicated, passionate workforce who cares deeply about the people that we work for, and to you know, improve the environment that we're working within. It's going to take pulling a number of different levers. One is obviously the SCHADS Award and the industrial arrangements. The other is the policy environment that we work within and getting those joined up responses. The other is around just having, you know, a drug strategy that gives us some direction and funding that follows from that drug strategy. So, you know, I think we're all here. We want to be here. We just want that environment to be supporting us and the system to support us to do the work that we're passionate about and that we want to keep doing.
Yeah, thanks, James. And thanks to everyone who's come along today and attended our event. We're going to keep these conversations going. We're going to continue to raise these issues in the context of the current parliamentary inquiry at the national level, the DAP reform process, also in relation to the development of the new national drug strategy. So please feel assured that this isn't just a talk amongst ourselves. We're going to continue to raise these issues and work together to try and bring these to the forefront of the development of policy and programs and funding structures moving forward. So thank you everyone for joining us today, and hopefully we will see you again soon. And we will be emailing you with additional resources, but if you miss the email, go to the website and within a week there will be the recording with a heap of other other resources there as well. So thanks everyone. Have a great afternoon. Keep up the good work.